Every day, more than 400 Canadians are diagnosed with dementia. By 2050, that number is projected to almost triple, reaching 1.7 million Canadians living with dementia. The majority of people who reach the advanced stages of dementia will spend their final years in a long-term care facility built on a care model designed for acute illnesses, for people recovering from something that will not get better, not for someone with a progressive neurological disease that will not. But there's a different model, and it has been operating since 2008. It's been studied across multiple continents. The outcomes are documented and consistent. And this video is about what that model is, how it actually works, and what the research says about it. And honestly, what is not working about it, because it's not perfect. And that part of the conversation is just as important as what is working. One distinction before we get into it, though. There is real confusion online between dementia villages, memory care units, and dementia day programs. All these have their own place, but they are very different things. A dementia village is a full-time live-in residential model. People live there, and it is their home. And that is what we're going to be covering today. The building that would become the world's first dementia village started as a conventional nursing home built in the 1970s in Weesp, a small suburban municipality just outside Amsterdam in the Netherlands. It operated for nearly 4 decades, the way long-term care facilities operate everywhere. It was an institutional layout. They had scheduled routines, clinical environment, a building designed around logic and managing illness. In the mid-2000s, a team working inside that facility began asking whether the model itself was the problem. Not how do we run this more effectively, but what if the entire logic of how we have organized this care, this building, the staffing models, the daily rhythms, was possibly wrong from the start. In 2007, the old nursing home closed, and in 2008, the Hogeweyk opened in its place. Journalists from more than 40 countries made the trip to Weesp in the years that followed, because what they found there looked nothing like any of them had expected to find in a care facility. The Hogeweyk is a neighborhood at its core. Within a fully secured perimeter, there are 27 homes, 7 people living in each one. 188 residents in total, all living with advanced dementia. Each home is a living room between 70 and 100 square meters, a kitchen, private bathrooms, private bedrooms, a balcony, laundry, storage. Then you step outside and there's a street, a courtyard, an alley, a square, a supermarket, a pub, a restaurant where residents of the local municipality can dine in among the residents of the Hogeweyk. There is a theater, a hairdresser, and even physiotherapy. Residents have the autonomy to move throughout this neighborhood freely, at their own pace, on their own. Nobody is escorting them. The perimeter is fully secured, but within it, the movement is completely free. Here is the design principle everything else is built on. When someone moves into Hogeweyk, the team does not build a medical chart first. They build a life profile. Where does this person come from? What kind of home did they have? What did they eat? What mattered to them? What was their relationship to their community, their neighborhood, and their daily life? Then they're placed in a home which reflects a distinct lifestyle from contemporary Dutch society. The goal is straightforward. The environment around you should feel like a version of the world you actually came from, a world that is important to you. Because what the research on dementia and environment tell us is the moment you surround someone with clinical signals, uniforms, a medication cart in the hallway, overhead announcements, you broadcast a message that registers even when conscious memories cannot. That message is, you are a patient here. You are being managed. For someone living with dementia, that message produces exactly what we are trying to prevent: fear, confusion, agitation, and frankly, the idea that this place that you're in is not your home. Familiarity does the opposite. Not because it restores memory, because it does not, but because the nervous system recognizes something it cannot explain. The design removes the clinical signal and replaces it with something that's so familiar and intrinsic to what the people are used to. The people inside the Hogeweyk, they look like neighbors. They wear regular clothes. They cook alongside residents. They sit at meals. They walk the same streets. But what operates invisibly inside that design is a full clinical community. They have nurse practitioners, psychologists, occupational therapists, social workers, volunteers, and the residents' own family and friends. They're welcomed as participants in daily life, not as scheduled and controlled individuals. The invisibility is an intentional choice. The interaction changes when the person beside you does not look like a staff member. The exchange stops becoming clinical, and it becomes, as much as the disease allows, daily life. The research on Hogeweyk and comparable models is consistent across documented outcomes. You get better cognitive outcome, increased functional capacity compared to residents in traditional care settings. You see improved social involvement, better physical and mental health, more autonomy, less stress, less physical strain on both residents and staff. Almost no bedridden residents because people are moving, because they have somewhere to go. Reduced and in many cases eliminated use of physical restraints and significantly lower antipsychotic medication use than in traditional nursing home settings. For anyone who understands what antipsychotics do to someone living with dementia and how they negatively impact cognition, increase fall risk, and accelerate deterioration, this is not a footnote. That is one of the most important documented findings in this entire field. They do not experience themselves as institutionalized. They report dignity, a sense of normal life. And families report high satisfaction scores, measurably lower caregiver guilt. And if you've ever had to make the decision to place someone you love in memory care, you know what that means. You make the decision because you cannot see any other reasonable option. And then that choice, it stays with you. The village changes that question. I need to take a moment here to ask you to consider becoming a member of the village on Patreon. For less than the price of a Starbucks coffee each month, you help us keep breaking dementia stigma, one conversation at a time. The link is in the description and in your show notes if you're on the podcast with us. This Dementia Village model has spread because once people saw it, they couldn't unsee it. It actively challenged the way that memory care could operate. Instead of a cold clinical hospital-like setting where hope is sometimes rare, there's residents where they're excited for each day. Because of this remarkable idea, today there are dementia villages operating around the world. In British Columbia, Canada, in Australia, New Zealand, Italy, France, United States, all over the world. None of them are identical though, and that's the point. There is no single blueprint. The philosophy is the blueprint. The environment, it reflects the people living in it. Their history, their culture, their way of moving through life. A village in rural New Zealand looks radically different from one in suburban Netherlands, and it should. What unites them is a single design principle. The person with dementia is not the problem to be managed. Instead, the environment is the variable that we can change. And there are other models that are asking the same question from entirely different directions. In Japan, a restaurant called the Restaurant of Mistaken Orders took this philosophy somewhere else. It is a restaurant staffed entirely by people living with dementia. Guests know going in that they might not get what they ordered. People were captivated by the idea, not because people pitied the servers, but because the servers themselves described confidence, capability, and a sense of belonging within the world. The project's premise was not, can people with dementia do this? It was, is society willing to make room for them? The village says, we built a world that works for you. The restaurant says, come into our world. You belong here. These are two different answers, the same belief underneath. Neither one treats the person with dementia as the problem to be solved, which is where the critiques begin, and they deserve serious engagement. The constructed reality argument. Hogeweyk operates in part through a constructed reality. Residents often do not know the supermarket is inside a care facility, that the person cooking beside them is a nurse practitioner, that the street does not extend past the perimeter. Is it ethical to construct a reality for someone who can no longer meaningfully consent to that construction? The therapeutic case is documented and strong. The ethical cost of the illusion is real. There's no clear resolution here, though. But the question deserves serious thought rather than dismissal. Cost, access, and the equity problem. This is where the critique becomes more serious. Hogeweyk works in the Netherlands because it operates through the national health system. The per-resident cost is compared to a traditional nursing home because the government restructured how care funding flows. And that is not a detail. That is the mechanism the entire model depends on. Remove that layer of government commitment and the dementia village becomes a product. Private dementia villages operating outside national health systems charge rates most families cannot afford. And the model with best documented outcomes becomes primarily accessible to people with money. That divide is real, and it's growing. In Canada, the problem has a specific structural shape. Long-term care funding is specific and intentional. Provincial funding covers documented clinical interventions, assessments, procedures, documented care. What it does not cover are the supports that define the village experience. The programming, the pub, the supermarket, the craft club rooms. These are categorized as amenities, and they may not meet provincial funding requirements, which means that within a system designed to provide equitable care, the most humanizing elements of the model may be structurally excluded from public funding. Without government willingness to reclassify what it counts as care, to say that a town square is a therapeutic environment, not a luxury, the model cannot be equitably scaled. The result is a divide not just between countries, but within communities, between families who can pay privately and families who cannot. Person-centered care becomes a premium offering rather than a standard of care. Dementia villages are often considered to be more humane than alternatives. The research supports that clearly, but they are still institutions. The argument is that we have built a better bubble rather than genuinely integrating people with dementia into community life. The restaurant of mistaken orders points in that direction. Not we will build you your own world, but come into ours. You belong here. I think that's the right long-term direction. But while we work towards it, real people are in long-term care facilities this week. A better institution is still better than the one we have. The question is not perfection. The question is, what is better than what we have presently, while we build toward what we actually want, the end state and end goal that we're really looking for. So given all of this, why aren't these being built everywhere? This is a question that I've been wrestling a lot with. And I believe it is because systems were not built for people. They're built for processes. Long-term care in North America runs on acute billing logic. Reimbursement flows towards clinical interventions. Procedures are documented, and then their assessments that happen every day need to be filed. There's no billing code for a town square. And there are too many physical barriers too. Building codes, they're written for institutions like hospitals. Fire regulations state that you need clearly marked exits. And if you ever supported someone with dementia who wanders, you understand immediately why a clearly marked exit is not a safety feature in that specific context. It is the problem. Zoning laws have no category for something that is simultaneously a neighborhood and a licensed memory care facility. Then there's the workforce. In Edmonton alone, there are 22,000 people living with dementia today. Across Canada, the number is 772,000. And it's projected to reach more than 1.7 million by 2050. More than 90% of people with dementia in this country live at home. They're cared for by their family members. You and I know who those people are. And according to the Alzheimer's Society of Canada's landmark study, Canada will see a 188% increase in the total number of care partners by 2050, and a 193% increase in unpaid caregiving alone. Alberta is expected to see a 290% increase in care partners and 300% increase in unpaid caregiving hours. That's not a staffing gap. That is a caregiving crisis building in plain sight. We do not have enough people for the model we have, let alone the model we should have. However, the reason we are not building dementia villages is not because we do not know how. The blueprint exists. It's well tested and well thought out and well proven. Communities around the world are building versions of it right now. The reason is that our systems reflect a belief, usually unspoken, almost never examined, that the final years of a person's life do not require the same investment as the earlier ones. That once someone's memory starts to go, what they need is safety, containment, and management, not joy or purpose. I think that belief, it comes from fear. We are collectively afraid of cognitive decline in a way that makes containment feel a little safer than meeting and interacting with it directly. The village says, we see you. Come be a part of this. The institution says,
stay here. We will manage this.
One of those beliefs is written into every funding formula, every staffing ratio, every building code and long-term care system. And it is the wrong one. Honestly, the world does need more replicas of Hogeweyk. It is important to consider, though, that the Hogeweyk is just one model. built in one suburb around one country's cultural life, funded through one national health system. Transplanting it where the funding does not exist, where the culture is different, where the people have different histories. That's not the point. The point is the question it was built to answer. How do we let people live with dignity, with familiarity, and with purpose in the time that they have left? What does that look like in a Northern First Nations community? What does it look like in an immigrant neighborhood in a Canadian city? What does it look like in a rural town where there's only 12 families and each have known each other for over 40 years? None of these answers or communities look the same. They don't look like Weesp, Netherlands, but all of them can be built on the same belief that a person with dementia is still a person, still capable of feeling dignity, connection, and familiar comfort. That those things are not amenities. They are the entire point of care. Because here's what I keep coming back to. If you were in the late stage of this disease, if your memory was going, and if you didn't know what day it was or where you were, you would still feel the difference between a locked ward and a street you could walk in. You would still feel the difference between being managed and being known. And we are choosing right now the systems we fund and the facilities we build and the policies we write, which of those experiences to give people, the people we love and the people we care about. Not someday, but right now. How do we build an entire system of care and leave out the part about living? Tell me what person-centered care looks like or doesn't look like in your community. The more of us having this conversation, the harder it becomes to keep building the wrong thing for our loved ones. If this conversation meant something to you, consider becoming a member of the Village on Patreon. Link is in the description. And if you haven't already, please like, comment, and subscribe. It really helps have more people find this important conversation.